welcome to the Superior Health Quality Alliance Home Health Agency Workgroup meeting. My name is Janelle Shear. I'm a Quality Improvement Advisor for Superior Health. As we continue the Home Health Value-Based Payment Series, our topic today is improvement in management of oral medications. So this work group has been going for a few years, but our goals for 2024 have been for us to just have an opportunity for home health agencies across Michigan, Minnesota, and Wisconsin to support each other by sharing ideas, current information, and best practices. We use the Discover and Discuss strategies to help your agency provide best care for their patients. So before we get into the content today, let's do introductions. So you can either unmute and share your introduction with your name and title, organization, what state you're in, and then your favorite summer activity. Or you can put it in chat and Lisa will read the introductions. So while you're thinking about that, I think I'll go ahead first. I'll have our team do their intros and then we'll ask all of you to introduce yourself as well. So I'm Janelle Shear. I'm a Quality Improvement Advisor at Stratus Health, my home agency in Minnesota, part of Superior Health Quality Alliance. And I'm going to say my favorite summer activity, I don't know, I'm going to say gardening. I love to garden. I have a nice big vegetable garden in the backyard that I actually like to go out and do some weeding before I start my day. Christine.
Yeah, hi. I am Christine Lamb. I'm a Quality Improvement Advisor at Superior Health. My home organization is Metastar in Madison, Wisconsin. My favorite summer activity, oh boy, I have a bunch. I mean, Janelle, gardening is one of my favorite activities, but I also really like to go canoeing and camping.
Great, and then we'll go to Lisa, and Michelle, I'll have you on deck.
Yes, thank you. So Lisa Gall, I am also from Minnesota through Stratus Health as part of Superior Health Quality Alliance. I live in the central part of the state. I'm lucky enough to live on a small lake in central Minnesota. So my favorite pastime is going out on the deck in the evening and watching the sunset and fishing.
Nice, great. So Michelle, I saw your hand up. I'm not sure if you had something. Did you want to introduce yourself?
Yep. I just thought if we kind of stay organized and I don't interrupt.
Thank you. So I'm going to say Michelle and then Amanda.
So my name is Michelle Vosick and I am from Good Shepherd Home Care in Sauk Rapids, Minnesota. My favorite summer activities is gardening as well, and my flowers. I have a lot of flowers, and I love to go camping. That is my means and ways of de-stressing. So
nice. Welcome. Amanda and then Tony. Oh, Tony had hers in chat, so we'll say Heather.
My name is Heather Sakeli. I am the Executive Director from Shared Services Home Health Care in Michigan. And all of your guys' summer activities are things that I enjoy doing as well, but my favorite is boating. So.
Nice. Thank you, Heather. Amanda and then Kate.
Good morning, everyone. So I am Amanda. I'm the Learning and Development Specialist for our home health agency, Corso Care, which is in Michigan. My favorite summer activity, that's hard to pick because there's a lot of things I like to do, but I would probably say kayaking is one of my favorites. I live near a lot of lakes and rivers, so.
Oh, nice. Thank you. Nice to have you here. Kate and then Karen.
Hi, I'm Karen Skeeth. I work for My Michigan Home Care. I'm the quality and safety nurse. My favorite summer activity is to walk beaches and find pretty rocks to collect. It's therapeutic.
Awesome. Thank you. And Kay, I saw you are unmuted. Okay, let's go to Michael.
Hi, everyone. My name is Michael Doris. I'm with National Government Services. We are CMS home health and hospice Medicare administrative contractor for Minnesota, Wisconsin, and Michigan. And my favorite summer activity is actually doing a lot of yard work. I like doing yard work. It's my de-stressor, so love doing that.
Awesome. Welcome. And Kay, are you able to do your intro?
She's off mute.
Yeah, I wonder if her audio isn't working. So Lisa, if you would just
Yeah,
read
I'm
Tony's.
going to read Tony's, and then Kay, maybe if you want to just type yours in, if you're unable to, we can't hear you if you're speaking. I'm sorry. So Tony Franzine from Aspirus in St. Luke's in Duluth, Minnesota. Currently, she's renovating a house with her sister.
Great. I mean, don't we just love those of us? All of us live in the northern cold states, and we just love summer. It sounds like we all do here, and there's so many fun things to do. All right, I see Kay has, yeah, her audio isn't working. So Lisa, if you'd like to read.
My
hers.
audio isn't working, says Kay Rennie from Henry Ford HHC in Detroit, Michigan. Favorite is gardening. Yeah, and as all the deer ate off all the flower tops last night while I was sleeping.
Oh, welcome everybody. And let's just dig into our presentation today. So just a little background of the 2024 sessions. We've been focusing on the home health value-based payment, the expanded version. So we've had 2 sessions already where we talked about an overview, the functional score. Last month, we talked about improvement in dyspnea. Today's topic is going to be the OASIS measure, improvement in management of oral medications. And then next month, we will be talking about best practices in care transitions. So look forward to hearing what has worked for you and to learn from each other there, and also some evidence-based practices. So today's topic is documenting improvement in management of oral medications. We'll be just doing a review of the expanded home health value-based payment. As we talked before, but I just want to do a review for those that might be new. Documenting improvement in management of oral medications. So we'll look at the OASIS and how to capture the measure scores, and then talk about some interventions from the evidence to improve the management of oral medications in home health patients. So this slide gives an overview of the expanded home health value-based payment. Basically, Medicare is shifting reimbursement from a volume-based payment method to one that provides reimbursement based on quality. In the pilot of the home health value-based payment, which was in quite a number of states over a fair number of years, they did see improvement in quality scores for home health agencies and patients, and also there was a cost saving. So now they are expanding it to the whole nation, and it's called expanded home health and value-based payment model. The measure set began in January of 2022 for all states, with the performance year. The performance year was 2022. It was also a learning year, and then the payment for that 2022 performance year is 2024, so right now. So this year's performance, so 2024's performance, will apply to 2026 payments. And it goes like that every 2 years. So there's a 2-year gap between performance and then what your payment will be. And you receive notice from CMS what your payment will be for that year. So in our series, we're addressing the 3 OASIS-based measures in the home health value-based payment model: the discharge function score, the improvement in dyspnea, and improvement in management of oral medications. So the next slide shows a table of the quality measures and the years that they apply. So you can see there's on the far right are for calendar year 23 and 24, they were the same. And the X's indicate which measures are being used to calculate the performance. you'll see there are some changes happening in 2025. So for example, the discharge function score measure is replaced by replaces two total normalized composite measures. So you can see the total normalized composites will not be on the 2025, but instead it'll be the discharge function score. And we talked about that a couple of months ago. For the claims-based measures, they are replacing those. And then the home health CAHPS measures are all the same. So I'm just going to pause here to see if anybody has comments or any questions so far. I'm assuming your trade associations and you've attended a lot of conferences and maybe webinars on this. Are you feeling pretty comfortable about the expanded new payment model? Just give me a thumbs up or something like that. I saw Amanda nodding her head. Yeah, okay. So this is probably just a refresher for you, but it continues to evolve, so over the years, so CMS may add or take away some measures. So you have to keep up on the education. Thanks for the thumbs up. Okay, so let's get into the actual OASIS measure, the M2020 on management of oral medications. So this information comes directly from the most current OASIS manual. And I just wanted to go over some of the tips that they give. So this is the actual measure. Patients' current ability to prepare and take all oral medications reliably and safely, including administration of the correct dose at the appropriate intervals. It excludes injections and IV medications. And then just a note, it refers to ability, not compliance or willingness. The intent of this measure is to identify the patient's ability to prepare and take all oral medications reliably and safely on the day of the assessment. And the time points that you collect it for OASIS are start of care, resumption of care, and discharge from the agency. CMS gives specific instructions for this measure, which I thought were really helpful. So observation demonstration is the preferred method for your assessment, followed by patient and caregiver interview and review of referral information. So the intent of the item, as I've already said, but it's really important, is to identify the patient's ability, not necessarily the actual performance. So willingness and adherence are not the focus of these items. These items address the patient's ability to safely take oral medications given the current physical and mental, emotional, and cognitive status, activities permitted, and environment. There's a lot that goes into the assessment of this question. The patient must be viewed from a holistic perspective in assessing ability to perform medication management. And ability can be temporarily or permanently limited by things like physical impairments. For example, maybe limited manual dexterity, can't open bottles, emotional, cognitive, or behavioral impairments, maybe memory deficits, impaired judgment, perhaps even fear, sensory impairments like impaired vision, having too much pain, or environmental barriers such as access to the kitchen or the medication storage area. Maybe there's stairs that are a problem now, or doorways are too narrow. So it can be impacted by all kinds of things. The assessment includes all prescribed and over-the-counter oral medications that the patient is currently taking and are included on the plan of care. It excludes topicals, injectables, and IV medications. And only medications whose route of administration is oral should be considered for this item. And medications are oral if they're placed in the mouth and swallowed with absorption occurring through the GI system. medications administered by other routes like sublingual, buccal, swish, and expectorate, or administered through a gastrostomy tube are not considered for this item. It includes assessment of the patient's ability to obtain the medications from where it's routinely stored, the ability to read the label, or otherwise identify the medications correctly. For example, if someone is unable to read and or write, maybe they put a special mark or a character on the label so that they know the difference between their medications. You assess the ability to open the container, select the pill or tablet or milliliters of liquid, and orally ingest it at the correct times. If the patient's ability to manage oral medication varies from medication to medication, consider the medications for which the most assistance is needed when selecting the response. So if they can take most of their medications correctly, but not one or two, that's what you use for the assessment when you're answering the OASIS question. If a medication is ordered PRN and the medication is needed by the patient on the day of the assessment, and the patient needed a reminder to take the PRN medications on the day of assessment, you would answer code 2, which we'll look at on the next slide. Able to take the medications at the correct times if given reminders by another person at appropriate times. If the patient didn't need any PRN meds on the day of the assessment and therefore no reminders were necessary, then assess the patient's ability based on all the medications scheduled to be taken on the day of assessment. So those are the instructions. And then now let's just talk a little bit about the actual coding. So how you would answer the questions. So code 0, which says able to independently take the correct oral medications and proper dosage at the correct times. You answer this one if the patient is able to manage all oral medications without assistance. And this includes if the patient sets up their own planner device and is able to take the correct medication in the correct dosage at the correct time as a result of using this device. So that would be a 0. And we know the lower the score, the more independent they are. Or if you go from a higher number like 3 to a 2 or to a 1, that would then show improvement. Okay, code 1, the patient is able to take medications correctly if, so the big word is if. So if they can take their oral medications, but another person must prepare individual doses in advance. So for example, place medications in a medi planner or another device. Or another person in the home must modify the original medication container to enable the patient access. So for example, removing a child-proof lid, maybe somebody's just not strong enough or can't get that lid off, that requires assistance. Or marking labels for the visually impaired or those who can't read. Or someone in the home must develop a drug diary or chart, which the patient relies on to take the medications appropriately. Those situations would all be a code 1. Code 2 is they're able to take the medications at the correct times if reminders by another person is given. If daily reminders to take medications are necessary, regardless of whether the patient is independent or needs assistance in preparing individual doses, for example, setting up a medi planner or developing a drug diary or chart. Reminders provided by a device that the patient can independently set up and manage are not considered assistance or reminders. And then code 3, which is unable to take medications unless administered by another person. If the patient doesn't have the physical or cognitive ability on the day of assessment to take all medications correctly, so the right med, right dose, right time, as ordered, and every time ordered, it has not been established that they set up a diary or reminders have already been or will be successful. So the clinician sets those up, then you would need to return to assess if the new interventions, such as the reminders or the medi planner, are actually making it so the patient can take all the medications safely. So Some coding tips are for the patient who lives in a facility such as an assisted living facility where the facility maybe holds or locks up the patient's medications. You report the patient's ability to take the correct oral medications, including proper doses, reliably and safely at the correct times. And you want to determine ability based on observation and assessment of the complexity of the patient's drug regimen, as well as patient characteristics. So think about cognitive status, visual status, strength, manual dexterity, and general mobility. And one-year assessment includes, can the patient get to the location where the medications are routinely stored at the correct times? Can they recognize the correct medication doses and take their oral medications, recognizing that someone would need to make the medications available to the patients once they're at the location? So if they're in assisted living, for example, like, do they have to go to the nursing office, or is there a medication cart? Okay, so I just like to ask, does your organization have other strategies for coding? So what are the tips that you give your staff when they're coding this OASIS question?
Some of the tips we use are similar to what you're saying. One of the things I try to teach them, because I am OASIS certified, is that start all your thinking with how do they do with M1860? Because the vast majority of the questions are asking about ambulation. So before you answer this question, go back and think about, what did you score that patient for ambulation? My home health agency happens to have be first choice provider for our senior care buildings. So Leisure Living, Independence Village, Story Point. So we have a lot of trying to grade for that question. And I've done a lot of education about how to think about it at admission and discharge. And we've seen a nice improvement, which I'm pleased. But definitely thinking about that, also thinking about the fact that, yeah, you need to think about, what did you answer in the rest of the OASIS? What did you score the BIMS? What did you score the M17, is it 40? The cognitive function. Did you say they have a memory deficit and they're forgetful at times? Well, then how can they be good at their meds? How does this jive, right? So talking about all of those pieces also. Yeah, and I also kind of push through the point that you made too, also that you have to look at how successfully they take all the medications and for which ones they need the most help. If the most help is that one that they struggle with and they're not getting it right, or they just are confused about how to take care, they're not really certain, they're not independent, friend. So yeah,
Amanda, those
like
are really good points. You know, the consistency across the scoring is really important, is what you're saying, is that you really need to match this up. Not only are they independent here, or are they dependent here, does that match up to what you just said in a different area of the OASIS?
That's exactly.
And then there's another comment in here from Karen to really pay attention to doing this safely and to focus on their ability, not what they are currently doing, also to score from the bottom up. When you're saying scoring from the bottom up, can you explain that a little bit?
So like looking at number 3, unable to take the medication unless administered by another person, to start with that one rather than start with 0, able to independently take the correct oral medication, just to work from the bottom up of the list. Because sometimes staff start from the top and don't really thoroughly look at all of the options.
Yeah, great advice, great point.
One other point I was going to make, because we have a lot of senior care buildings and the people in the buildings are not LPNs, right? So our pharmacists group the medications into packaging. So remember that grouping before it gets into the home does not take down their ability to safely take medications. And a lot of nurses will think that, because why else are we doing it unless they can't manage it otherwise? So in their mind as a clinician, it's like, that should decrease it, but I have to remind them it doesn't. And that becomes important when we do discharge from OASIS and thinking about how to use clinical judgment to score that. So that was definitely one of the biggest eye openers, was knowing that. Thank you.
Thank you, Amanda.
Anyone else have any tips that you use with your staff on assessing this question? I know when I worked at a home health agency a few years ago, when the nurses would tend to notice that the patient needed their meds set up because they couldn't do it. So they would document the OASIS after they set up the meds. But you really want the assessment before you do the intervention, right? So then the next time you complete the OASIS, they would have shown improvement. Otherwise, it may be the same or no improvement would be showing because you've done the intervention, but when you walked in the door, they couldn't properly take all their medications without your assistance. Does that make sense? Anybody else experience that? Yeah, no. I mean, OASIS, okay, thanks, Karen. OASIS has been around for quite a while now, but there's constant turnover and change in staff that need to learn how to do this very important assessment. All right, so should we go ahead and move on? Now we'll talk about some strategies for improving medication management. And so here I'm talking a little more globally about medication management, not specifically to the M question. So providers can use strategies focused on medication reconciliation and medication adherence to facilitate safe care transitions and medication management. So we'll look a little deeper into each of these. Medication reconciliation is the process of comparing the medications the patient is taking and should be taking with the newly ordered medications. The purpose of medication reconciliation is to develop an accurate patient medication list and to resolve any discrepancies that are discovered. Important considerations include who in the home health agency will conduct medication reconciliation with patients and when it will happen. So I just want to ask, what % of times do you think when you admit a patient to home health that there is a medication discrepancy where you have to try to resolve that? What's your estimate on that?
I think a fair question is how many of them are looking beyond the medication prescription bottles? If they're looking at everything that patient has in the home, I would say greater than 95% of the time.
And there's an
I
answer
agree.
from Tony as 90% in the chat. It's an estimate.
And Michelle, I see you have your hand up or thumbs up.
Yeah, I agree. I agree with Amanda. What's even more interesting when it comes to the medication reconciliation, we just were surveyed about 30 days, about a month ago. And one of the things that they found for us is that reconciliation piece is not just the medications that, again, developing a medication list, but that with every skilled nursing visit, they want us to see, did you, when you do your comprehensive assessment, for example, if you have someone who has constipation and they have a medication that is on your med list as needed, that clinician is actually going one step further to say, did you use the medication? When you use the medication, is it effective? Those types of things. So they really, even from a survey standpoint, they're even pushing this medication reconciliation even further. The other component is, and what we ran into is the other part of that whole process was that we were doing a medication setup, and we have a number of VA clients, and when the VA sends their medications, they send 6 to 8 bottles of the same medication to maybe last them a whole year or for a whole 6 months or 3 months. And then they will put on the pharmacy label, for example, on a Miralax, they'll send out 8 bottles of Miralax. And the pharmacy label says that Miralax should be discarded after this particular date. Well, the manufacturer's date is like 2 years out. And there's no way that this human being is going to be able to use 8 bottles of Miralax within a 6-month period of time that we're there. So this listing is that we actually kind of asked the question about, so what expiration date do we use in our reconciliation? Because it's a huge cost to that particular client and a detriment financially to throw away 7 bottles of Miralax when it really doesn't expire. So we actually pushed back just a little bit, and they are asking us to look at either marking open dates. We can use the manufacturer's date if there's a discrepancy, but then our policy has to reflect such. So we did some real working around, and again, taking that medication reconciliation even 2 steps further, actually, that it's not just about creating that list, but really looking at and assessing your meds every single visit that you're there, and whether or not they're effective. And if they haven't used them in 6 months to a year, they're strongly suggesting you take it off of that list completely. So it gives medication reconciliation a whole different look. And not only that, but increases our time within that visit that's there. Especially for those people that maybe aren't necessarily all short term, but maybe some of our medical assistants type of folks, or are longer, or what we call chronic folks. So it's interesting, but we've actually really dove into this particular piece within our agency.
Thank you for sharing that. Yeah.
Yeah.
Heather, I saw you had your hand up. Did you have something you wanted to add?
Oh, our agency during survey, meds were really hit hard for us with the reconciliation piece. We have our staff putting into the medication profile if the patient is taking it different than how it has been prescribed, and we're making sure the provider is aware and documenting that piece as well.
Great, thank you.
Yeah, we had to do that on a couple of ours as well, or family will go buy a different dosage and then change how it's used. So we got caught up in that whole process as well.
Medications are complicated, aren't they? Very complex. And I can feel for you going through your survey and having them find those things or want those things for you. Okay, should we move on? So according to the literature, medication reconciliation has been described as a 4-step process. The first step is to verify all medications prescribed and taken. The second step is to clarify medications, dosages, and frequencies. 3 is to reconcile discrepancies with the prescriber, which may include the resolution of any potential adverse effects and drug reactions. And the 4th step is to communicate an accurate medication list with the patient, caregivers, and providers. So it's important to consider the timing of the medication reconciliation process to promote improvement and prevent adverse events. Consider conducting MedRec when medication changes have occurred or are most likely to occur, and during visits in preparation for the patient's self-management of the medications and discharge from home health care. Examples include during the visit following the referral to the home health agency, so when you first start someone up, when there's a change in a patient's condition, and when a new patient medication orders are received. The time points for the OASIS data collection are to be considered as well, and include patient assessments at the start of care, resumption of care, research, and preparation for the discharge of the home health agency. So let's dig a little bit deeper into these steps. So let's look at a patient scenario regarding the medication reconciliation in context of a care transition from hospital to home health. So it's in the blue on the slide. Hopefully you can read it, but I'll just kind of summarize it here. So in this scenario, the home health agency receives a referral. the agency RN reviews the referral for a list of prior medications and new medications orders. The RN calls the patient to schedule the admit visit and asks the patient to have meds available, including containers, any discharge instructions, and all over-the-counter medications that they take. To verify all medications prescribed and taken early in the admission visit, the patient shows the RN each medication and verbally states the frequency, dose, and their understanding of why they're taking the medication, so the purpose of it. During this step, the RN reviews the medication lists, looks at the containers, so actually picks them up and looks at them, and the packaging, and verifies all medications prescribed and taken. Next, the RN clarifies medications, dosages, and frequencies with the patient. So the RN and patient discuss any questions raised about the medications and the schedule. And it's during this steps that discrepancies are identified. During the step three, the admitting RN contacts the physician's office to reconcile the discrepancies. The RN enters any new or updated medication orders for the patient in the home health agency medical record. And then during step 4, the RN communicates to the patient the new and/or change medication orders. The RN provides an accurate medication list and information to the patient and family caregivers as needed. The RN identifies and communicates medication updates and changes to the medication schedule to the agency team and other identified providers as appropriate. Medication adherence. So this is the second strategy to improve medication management, and it's to promote medication adherence. Understanding the patient's adherence to the intended regimen is important to assessing the patient's medical condition and any adverse events that might arise. Medication adherence is the extent to which the patient's or caregiver's medication administration behavior coincides with medical advice. So are they following the medical orders? The home care clinician's assessment of medication adherence provides an opportunity to identify barriers and to mitigate risks associated with medication administration not aligned with medication orders. As a result, clinician assessment and decision-making incorporate medication management information and an appropriate plan. So let's just stop a little bit, and I'd like to hear how your agencies assess for medication adherence. What are some things your clinicians do? Is there anything structured in your EMR or your assessment documents that you assess these medications?
This is Heather from Shared Services. We have in our EMR the staff are to review the patient's medications at every visit and identify if there's been any changes. It's also part of our policy that the staff are looking at the medications at every single visit, regardless of the discipline type.
Thanks, Heather. So your therapists are also reviewing medications?
That is correct.
Mm-hmm.
They have to coordinate with an office nurse on any changes or discrepancies to get it clarified. But at the same time, they're still the ones in the home responsible for looking at those meds every visit and then reporting it off.
We do that as well at My Michigan, and we've built in some verbiage in the EMR of specific things that they have to look at and document against. But we still struggle with compliance on accurate medication lists in the home, and surveyors have struggled with the accuracy using Epic as an EMR because there just are barriers to that one clean medication list from the physician's offices and discharge from the hospital and the patient home. So it's still just a really frustrating process.
Yeah, I agree with Karen. It is a multifactorial impact. Even like sometimes just getting the doctor's office to get back with you and clarify timely can be a massive struggle.
Yeah, absolutely.
One of the benefits that this agency has, and I've been doing a lot of rebuilding and structuring here to get to these things because I work for some huge home care agencies. But one of the things I want to get towards is helping them get stronger at this, but they kind of get lucky with the fact that over half our population is probably in these senior care buildings. And so medications are well managed in there by the staff, right? And the pharmacist setting these up. But one of the things I did at Trinity Home Health before, because the clinicians were struggling with writing a good medication list, especially the therapists, like insulin, right? It's in a vial. They don't write the sliding scale. Things, high risk meds or issues. So one of the things I did during the skills workshop is bring them in. Everybody got a turn with me. And we made it very interactive and very fun because adult learning says the more realistic it is and relevant to their job, the more they're going to retain it. So I made a whole ABS, got the headings right, everything. I designed this whole thing to have layers of complication and thinking it through critically. I acted like the patient. They had to interview me and show me, based on their practice, right? How far do they investigate? How far do they coach this patient, right? I threw in a herbal medication like ginseng. And then I had them write out, and I took right out of home care home base, the medication spot we have to fill things in. And I left white blank spaces. And I'm like, come in here and write out this med for me. Write out everything you're supposed to have on it. And then I go back over instantly with them before they left and reviewed it. So that way they got direct feedback right away to change their process. So we did see a really nice improvement there with a lot of the therapists about getting it written down right the first time. They also learned a lot about the value of like investigating with the patient, talking with them, seeing what they had. We had quite a few laughs with some of them. Some of them gave me the evil eye because I always be that difficult patient. One of the therapists said to me, Amanda, you missed your calling. What do you mean I missed my calling? What do you think I should have been? He's like, you should have gone to Hollywood and be an actress. I'm like, oh God. But they had fun. I mean, I made it realistic enough. I put pinto beads in these prescription bottles that I made.
I love that, Amanda. If there's a protocol that you have developed in that process and would love to share it, we'd love to have that on Connect.
I don't think I have a protocol, but I can share a process.
A process of some sort,
Yeah.
we love to share within our groups.
Yeah.
So if you have something that you've developed, that sounds very, very intriguing to me. Thank you for sharing.
I'm happy to help the
There's
team, but very lastly, I weighed the bottles down with pinto beans, right? And one of the questions was, okay, can you divide a warfarin tablet in half? When can you? And she's like, oh, well, she opens it up and she pulls out a pinto bean because she was about to tell me, well, if it's scored, and she looks at it and she goes, oh, this is a natural medicine in here. So yeah, we can share ideas.
Very nice. And there is a comment in the chart from Tony that intake, she says that intake ensures a med list on admission. Staff at times call pharmacy to get an accurate list if patients don't have one. And the intake nurse enters the meds in for therapy, then therapy reconciles at start of care and research and reports back to the intake RN. And that is part of med reconciliation. You cannot just take one list. You have to compare the patient's list with another list in order for it to count as a med rec.
All right, thank you. Thank you, everybody. Let's move on to our next slide, talking about medication adherence, steps to addressing influencing factors. So these include identifying barriers and potential reasons the patient may not be taking their medications as prescribed. Next is select tools and methods that can assist your patients to take their prescribed medications as intended, and then implement the plan and the actionable steps to support the patient's adherence to the medications as prescribed. Determine when and by whom each action will be taken. And let's go a little bit deeper into each of these steps. To identify and address barriers to patient adherence, a home health agency may want to consider the use of evidence-based scales or questionnaires that provide information to prompt planning with the patient to improve adherence. And on this slide, we show 3 evidence-based scales to assess medication adherence. And I was curious, Karen, you'd mentioned that your EMR lists specific questions. I was wondering if some of those are from one of these scales. So there's 3 scales we have here. The medication adherence report scale 5 / or it's called MARS 5. It uses 5 items from an earlier 10-item version to identify self-report of medication use. And so the studies for these scales are down below. The medication, let's see, in the study by Chan et al., they tested it with patients on medications for chronic conditions such as hypertension, diabetes, asthma, etc. And if they found, I mean, not surprisingly, that people that had good medication adherence had better control of their chronic condition, for example, their hypertension. And so the questions, it started out with 10, and it was a mix of kind of like positive questions and more negative questions about the meds. And it ended up being the 5 is more the negative. So for example, a positive one was, I take my medication regularly every day. A negative one might be, I take less than instructed, or I stop taking it for a while. I miss out on a dose. So there are structured questions, and this has been proven by research that by doing an assessment of a patient medication adherence, you can predict how they're going to take their medications and how their condition will be managed. The second questionnaire is called the Medication Adherence Questionnaire, and this identifies barriers using 4 items from an earlier 8 version. So it seems like they're cutting the number of questions down. And then the self-efficacy for appropriate medication use scale, the SEAMS, that might be considered more when more information is needed. And this is a little more complicated. It's a 13-point item with 3-point Likert type scales that measures barriers to medication adherence while focusing on self-efficacy in chronic disease management. So I'm curious, just maybe a thumbs up or raise your hand. Does anybody use an evidence-based scale when you're assessing medication adherence? I wasn't familiar with these either, but it may be something to consider. And I'm curious, Karen, if you have a chance, just maybe put into chat some of those questions that are in your assessment, because they maybe touch on some of these as well. And I don't expect you to have to go into the EMR and look if you don't have them on the top of your head. Okay, so identified barriers to medication adherence often fall into one of 5 overlapping categories, and there might be others as well. But factors related to the patient's social economic status, such as insufficient funds for out-of-pocket medication expenses, or the administration method, or lack of sufficient social support systems, the patient's treatment and therapy. Common issues include treatment side effects. Maybe they're having side effects from the medication, so they don't want to take it. Or the medication regimen is just so complex, or perhaps it's the methods of administration. The patient's personal health literacy. So that's the degree to which an individual can find and understand and use information and services to inform health-related discussions and actions for themselves and others. Common findings also include insufficient knowledge regarding medication and the patient's perception of the medication benefits. The patient's physical and psychological conditions, such as their medical condition and the ability to perform self-care tasks. Forgetfulness or impaired cognition can play a role in medication adherence. Factors related to the healthcare system, including delays with changes in medication orders and filling in prescriptions. And we've talked about that a little bit today as well, including issues with clarity across settings. Any other barriers that you've noticed for medication adherence? Okay, and thanks, Karen. Your questions don't touch on those. They're more regulatory based, and then they also have to indicate, oops, I can't see everything, that have a current up-to-date med list in the home. Okay, thank you. All right. So to support medication adherence, it's important to consider some tools and methods with specific patient populations. And these include easy to read, patient-friendly medication lists and resources. So I have a couple of examples here, and the websites are below. The example of the My Medication List, it's available free for download using the links on this slide, and then also at the reference list at the end of the presentation. This tool is available both in English and Spanish. And then you might want to consider medication resources for regular use. They include information on administration safety or visual resources specific to medications commonly ordered for patients and which are prone to safety issues or medication errors. So there's tools and resources on specific information. Again, consider providing these languages in languages that meet your patient needs. And many communities have patients that speak languages other than English. So just be aware of that and provide them in a language that they can understand. And the next slide shows another group of tools to consider for those use for safe dosing. And questions to think about including, are daily or planners readily available to clinicians when conducting an admission visit with a patient? And determining whether this method of medication administration would promote patient safety. So does your admin or nurse have these available or in their bag in case they need to use them? Is a system for medication pre-fills by the pharmacy important to achieve safety and medication adherence for a specific patient? Is that an option in your community? If it is, what processes should be followed to set this up in a timely manner to achieve accurate and safe dosing? And then if you do use that, think about at discharge from the home health agency, how will changes in the medication orders be facilitated and the pre-filled packaging be updated? Some patients may also benefit from an electronic dosing and reminder system to achieve adherence. And considerations here are usability, cost, how to update the dosing system when changes in the medication occur. You might need to involve social services or social workers to help pay for this service. So those are some examples. Key to achieving medication adherence is a patient-centered plan, which includes collaboration with the patient and, if appropriate, the family and caregiver. Consider using the patient-centered goal setting and shared decision-making to engage the patient and family caregiver. Discuss early on in the home health stay what's important to the person, what's important for the patient. Identify their preferred language and learning style. Some people need to see, read, hear multiple ways of learning. Engage the patient in a show me or using teach back and using motivational interviewing techniques. I think show me and teach back are probably pretty familiar. Motivational interviewing is a collaborative conversation style for strengthening a person's own motivation and commitment to change. Motivational interviewing is a person-centered, it's a style of how the provider or the clinician talks to the patient about changing their behaviors. Provide materials to enhance their understanding of their medications. You want to simplify the medication regimen and determine how the written medication list, schedule, and administration in the home will be kept. Teach the patient to take the current medication list and bottles to all medical appointments. And communicate the current list reflecting up-to-date medication orders at the time of care transitions. An effective plan for medication adherence also requires collaboration with other members of the agency team, the primary care providers, and other providers as needed, such as the pharmacists, for example. So this slide shows that by employing strategies that we've talked about today for medication management to routinely perform medication reconciliation, identify barriers, and tailor methods to enhance medication adherence, the goals of improving the quality outcomes via the OASIS measure can improve. There's decreasing costs, which are shown in claim-based measures, and increasing patient satisfaction in your HHCAPs may be achieved in the expanded home health value-based payment model. So we have a few minutes left for open discussion. We've had great discussion so far, but let's say you can pick any of these that you want to talk about, what your current challenges are, what strategies, if you have additional strategies to help your patients manage their oral medications, and then what steps might your agency take to improve your current strategies in helping your patients improve in their management of oral medication. We'll just open it up for anybody. I see Karen had to leave, but if you want to just unmute or put any more comments or suggestions in chats, we'd love to hear from you and learn from you.
One of the other challenges that our agency has, this is Heather from Shared Services, is even on our surveys that go out after the patient has discharged, getting them to remember that we talked about their meds and that we've reviewed their meds. Our agency really struggles with that aspect of the survey.
Same here,
That's
Heather.
interesting, Heather, because that's really, you know, that patient rating question also. So if they don't remember, they're not going to rate you that you've reviewed their meds with them. So how do you get them to remember that?
And sometimes we found out like it's been filled out by a caregiver or a DPOA that maybe is not an active DPOA. So there was not a consistent communication to them on the meds. But any suggestions on how to help them remember that meds have been reviewed and discussed multiple times? Like, I don't know how to increase that score.
Heather, we have the same struggle here. Yeah, we have the same thing because of a lot of our patients are in these senior care buildings. Usually they're getting help to fill out these surveys, and we find the majority of ours are filled out by others. So one of the things we're going to move forward with that I've strongly encouraged my team I work with here is that we need to start having time points that no matter what patient it is, as long as they have a patient representative or POA guardian, that maybe like at admission, during case conference, and some other time points, definitely discharge from agency, you touch base with that person and you say, hey, I've gone over the home for safety. Hey, I've gone over this medication list and I've resolved this and I've done that, right? So that way they can help the patient remember, because our median patient age here is 80. And so you can imagine what the memory recall is on that, right?
I
So
feel your
that's
pain.
a challenge. Yeah, that's a challenge for us too. And we're actively trying to find ways to go about it. I won't say I have anything that's successful yet, but those are some of the things we're looking at doing, is building that into expectations and having time points to speak to the person in their life.
It's a great suggestion, Amanda. Thank you.
You're welcome. If you come up with any good ones, let me know too, because we
I
have.
will. Are you over at the Story Point in Ann Arbor?
Yes. Yes.
I will love to stop by and say hi to you sometime. I'm over at the EHM in Saline.
Oh, wonderful.
So,
I'm at the Milford
around the
office.
corner.
Yeah, we should exchange emails here. I'm going to put mine in the chat. Okay.
All right. So our time is almost up. I'm going to have Christine kind of run through the slides. We do have a group in Connect, which is a social networking private group for us. So if you have tools to share, you can add that in there. And the link was put in chat by Lisa. Our next meeting is July 24th. We're going to focus on best practices and care transitions. Here are the references with the links to all the resources that I've talked about today. 2 slides of those, couple of some research articles, and we put in the CMS help desk regarding the extended home health value-based purchasing model. They have tons of great information and materials, and they keep adding things as it goes along. So we just want to have that as a reference. This shows the help desks there again. And here's our contact information. If you have any questions or you want to reach out to any of us, we'd love that. Here's our Connect, and thank you so much for being here today. Great discussion. Look forward to next month, the end of July for our topic. Thanks, everybody. Have a great rest of your day.